Hey everyone, thanks for joining. Tonight we're going live with Dr. Raul Singh, and I think he is here. Are you there? We see an empty hallway. There you are. Nope, no you're not. There you are.
Um,
Hi, Dr. Singh. So good to see
Good.
you.
Very good to see you. How are you doing, Cynthia?
I'm good. Adjusting. I just moved to a new house, so I know you understand. It's a
Oh,
lot.
yeah. It's a lot of work.
It is. It is. I just want to thank you, as always, for being such a big part of Learn, Look, Locate. I am so grateful I found you. We should tell everyone how we met. It was really early on.
Very really. Oh my gosh. I had a very small social media footprint, and I think I still do. But you found me. It's a pleasure, honestly. This was my message and my goal too, obviously, to get the word out and the knowledge out. And
And I'm so glad you.
Learn, look, locate for that.
I'm so glad. I mean, I want a platform for the medical community as well as the survivors, because every day I'm learning more and more how much we don't know, how much we need to know. And if we don't talk to you in this comfortable setting, in this relaxed environment that feels, I think, safe to a lot of people being on social media, we don't get time with oncologists. I mean, I just spoke to a follower. We can't talk to you guys. We get diagnosed and we're on our merry way. It's very difficult. So thank you for all you do, and thank you for liking social media, because you're really active now, and I think you have some groupies out there. So
And anything I can do to help promote the knowledge, I think makes a difference. And it's a lot of fun. I do enjoy doing this, and I think it's a fun way to get the information out that, you're right. I think that's the hard part. You get like a very short session with your oncologist.
Oh, very.
A lot of questions. You leave the room feel like you didn't get answered, and I think it's repetition. It's delivering the knowledge and the information in a different way that I think really can grasp people's attention.
Yes. You put it in such a lovely way, and as your page is on the website, we're trying to do this in a way that resonates. So without further ado, because I know you have a lot going on, tonight's topic is quite serious, and I want to respect that. I want everyone to know that I have not gone through Red Devil treatment, so I cannot relate, and I've seen a lot of the feedback from people that this has been, I'm going to get upset because I read it. It's very, very, very difficult drug. Very life-saving drug, but a very, very difficult drug. And my heart goes out to some of the folks that have been writing to me and to anyone privately that is suffering from the side effects. But what we're here to do tonight with Dr. Singh is to really at least bring a human touch to this very difficult treatment. And, that is my goal, guys. I mean, we're humans, and Dr. Singh has such a compassionate way of presenting the information and connecting with all of us. So thank you, first of all, for that, and I really appreciate your way of dealing with people. We're people going through some tough stuff, right?
Right. I mean, I think anytime that you hear that you have to get the Red Devil, or as I had mentioned in the Instagram story, it's called adriamycin. It's a chemotherapy at the end of the day, and it's actually very scary to put something toxic into your body. So understanding and knowing that there's a lot that goes behind when an oncologist makes that decision to say that this is what you might need for the treatment.
Yeah, let's kind of like dovetail right into that. So, we've talked earlier, who's a candidate for Red Devil? And when you make that decision, let's talk about that. It's because it is the most, from my readings, and studies, the most powerful treatment that can be given to a breast cancer patient. Is that correct?
That's correct. So the Red Devil is a drug that before we had any of these even targeted endocrine therapies, this was the most powerful weapon oncologists had to treat breast cancer, and actually very successful at treating breast cancer with this medication in combination with another chemotherapy drug. And so nowadays, it's now fallen down in the tier and sequencing of treatment for patients with hormone positive breast cancer, or even in people who are HER2 positive breast cancer. And it's fallen into the niche of people with what we call triple negative breast cancer. And that just means that there isn't an actual mutation or driving mutation for their breast cancer. So the majority of people who do get this drug are those who are what we call triple negative breast cancer patients. But having said that, there are a certain population of people who may have hormone positive disease, such as estrogen or progesterone positive breast cancer, who have such fulminant disease, meaning a very aggressive disease spread out throughout their body. We need to do something immediately to try to reduce their disease burden, to give them a better quality of life, and then change gears to a different treatment that's targeted. So in the short end of it, I think anybody, regardless of disease state and breast cancer, could get this drug. So it is important to know about this drug. But when we're talking about people who routinely get this drug that have breast cancer, mainly it's triple negative breast cancers.
It's good to know. How quickly, so let's say someone's getting a Red Devil treatment. How quickly is this potent drug killing those cancer cells? I mean, I asked that question. I went through radiation. I was so curious. Like, Dr. Rajendran, how is radiation killing cancer cells? Can you walk us through that? And then how long after, if there's any other cancer cells that might be circulating around? Is there a long-term effect of this drug?
That's an excellent question. So radiation is pretty, Dr. Rajendran probably mentioned, radiation is pretty quick acting. Chemotherapy, on the other hand, it acts quickly, but it takes about a week or two to start developing into the system of the body. And then it starts killing these cells. And that kind of also leads into what is this drug. It's a drug that inhibits the way our DNA forms in the breast cancer cells and in our normal cells. And so from that perspective, it doesn't, the second the Red Devil drips into your veins, it's not killing the cancer right away. It has to build up, and then it starts eradicating the cancer cells. So it actually takes, honestly, we call this nadir per se in medical terminology, but you start to see all the blood counts drop, and that's when you know the drug's really working, for the lack of a better word, and that can happen up to 7 days after getting the treatment. And so it's not an immediate acting drug, but yes, once the drug starts getting infused and gets going, then it's the lasting effect, and that's when we start to see breast cancers just shrink and melt.
Wow.
Amazing drug.
Talk about that. When you say amazing, I want people who are on here, with the negative, all the negatives. I read about it. Oh my God, the heart side of it. Let's talk about the positive, right, and then we'll go into the negative.
Yeah, I think the positive is that I think from all of our oncologic chemotherapy drugs, this, like I said from the beginning, this is the most potent backbone to all treatments. And so if one can get this drug, I mean, you can literally see inflammatory breast cancers, which are inflamed, involving the skin, shrink and almost go away. Large masses in many different areas will shrink pretty quickly, and almost sometimes, in some cases, we use this before surgery. If a stage 3 cancer, the tumor's too big, and we're trying to shrink the tumor down for more, maybe less aggressive surgery, we can put people in pathological remission before they even go to surgery, meaning there's no evidence of tumor. When they're going in to operate, the breast surgeon is going in to operate. So it's pretty, there are great positives behind this drug. I think it's really important to not lose sight of that. And when we're talking about this chemotherapy.
Before I get into the side effects, I want to truly understand when the drug is going into the system, obviously it's killing the cancer cells, but let's talk about the good cells.
Yeah, so that is probably one of the top 3 side effects that are even quote-unquote a black box warning with this drug, is that it causes something called myelosuppression, which just means it basically kills all the good cells in our body. Our white blood cells, our red blood cells, and our platelets, they can all drop, because that's what the chemotherapy is doing. It's not only affecting the cancer cells, but it's affecting our bone marrow in the way it produces these cells. And so, thankfully, we do have ways to protect our white blood cells, which are probably the most important because they help our immune system fight infections. And so we can give what we call growth factors, which are white blood cell shots to help protect our immune system a little bit from the chemotherapy.
So that is done often, white shot of what? That's interesting. I didn't know that.
Yeah. So it's a shot. It's a white blood. We call it for easy understanding. We call it a white blood cell booster shot. It has names with many different shots, and usually it's given 24 hours after you get to chemotherapy, and it kind of helps you get through that low point I was talking to you about, that nadir, what we call the nadir, where your counts, we expect your counts to drop the lowest, where your body is the weakest from the chemotherapy. And that helps prevent infections, because that's one of the biggest things we worry about when your white blood cell count drops because of the chemotherapy, being at risk for general infections that maybe a normal immune system would be able to fend off. In this situation, you can't, and that could really hurt you and delay your treatment if you were to get an infection. So try to do our best to protect people in those situations.
Someone just wrote, and Lisa, thank you for joining. I gave them to myself nightly. I love hearing this. I did not know this. For anyone who did not know about the white blood cell shot, we do have a newly diagnosed person and that is on, and I know I can't remember her name. It just went away here, but I know she's a bit frightened. She has written to me and on the page, and she's triple negative and will be getting the Red Devil. So it's really lovely to hear you present it this way, and the power, we call it the power in the red, and how it can really help. And I think we have to look at it from a long-term perspective that, we have to get rid of these cancer cells, right? I mean, we have to, right?
It's bar none the best option we have, part of the treatment for these triple negative breast cancers. Now, there are new things coming down the pipeline. I have mentioned, and I'm not going to talk about it too much right now because we're focused on the Red Devil, but immunotherapy is working its way into triple negative breast cancer. But again, it's in addition to this treatment. So it's more important to understand that we're going to get one day, hopefully, where no one has to get chemotherapy. But if you have to, this drug really provides a big punch towards the breast cancer.
Someone else received that shot as well. This is, wow. It's really, most oncologists are doing this.
Yeah, so I think it's pretty common practice. If you're not getting it, you should ask your oncologist why not. Now, there are some situations where people can't get this drug. If for some reason they have a really bad reaction to the drug, or sometimes if the interval of dosing of the chemotherapy is too frequent, it's hard to give forms of the white blood cell shot. There's one that's a long-lasting one, and there's one that's short-acting. So there should always be something you can get, and I think it's important to have that discussion kind of with your oncologist.
Yeah. So before I get into the side effects, I'm kind of saving that for last. Let's keep the positive going. I did some reading and some research about Doxil, which is supposedly safer alternative. Let's hear about this.
Yeah, so Doxil is an interesting drug. So it's actually what we call a liposomal anthracycline. So it's a different formulary of the Red Devil. It's a great drug. Right now, it's only being used in what we call the metastatic or stage 4 setting of breast cancer, and as a second-line treatment, meaning or not necessarily second line, but meaning you've tried something before and you're having to use that as a second-line treatment. It has advantages because the way it's formulated, its side effects are less. And I know
I read that
later, but you can get more of the drug with less toxicity. It's really only been used in a single agent, so not in a combination medications, but it is an exciting drug because we can actually give this drug to people who've already gotten the Red Devil before. And because we always worry about cardiac toxicity with the Red Devil, which I know we're going to talk about in a little bit, but that's something that is still a possibility with Doxil, but the risks are less. Understanding, and I know there's some studies going on about this, of being able to use it in adjunct with another chemotherapy and still have no side effects would be great, for treatment of breast cancer.
Okay, so good pivot towards the side effects, which is such a hot topic. As I posted tamoxifen not too long ago, we're all kind of screaming at you guys. You got to find a better way. I mean, we're miserable, we're cranky, and we want to feel good. And, how and why? I'm just going to rant for a second. Come on, guys, give me some hearts here because I know you're all feeling this. It's like, why are they not coming up with better medications? Because I know endocrine therapy is a whole nother Instagram live, but, there's a lot of resistance because of what the side effects. And some people might even turn down chemotherapy because of it. Just saying. I mean, thank you. I got a little heart there because, you read about it. We're Googling. We're going crazy. We're scared. So let's talk about that because.
Yeah, I mean, look.
And how to manage them.
Yeah, right. I think it's important to understand at the end of the day, it's chemotherapy, so it's a toxic drug going into your body that it's foreign. Your body's not used to it. So honestly, there are a lot of side effects that can occur with the drug, and it's important to be in tune with your body to know what you're feeling and what to bring up, and knowing what to look for when you're getting this treatment. And so there are a litany of side effects. I think it's important to group them. So I think understanding what will happen probably versus what may happen, right?
Mm-hmm.
And so knowing that this is a drug that's almost certainly going to cause what we call alopecia, which is hair loss.
Yes.
And so, not all chemotherapies do this, but the red devil is commonly associated with loss of hair, and that can be gradual or coming out in chunks, and it's not necessarily always right after the first treatment. It could happen as you go along. Now, it's important to know that there are things that we can do to try to reduce the risk of hair loss. So I'm sure we've mentioned this before. Cold capping is very, very useful. I think there's good research on it. And so offering that to patients, I think, is very, very important. But definitely while you're on treatment with this drug, alopecia is a huge side effect. Now, understanding that once you're done with the chemotherapy, you will get your hair back. So it's not a permanent hair loss.
We'll stop right there for a second because anyone, and I do want to pivot, cold capping doesn't work well with the red devil, someone's writing.
Yeah, it's not an imperfect situation. I agree. It basically is helping freeze those hair cells so that they're not affected as much by the chemotherapy. But nothing is absolute, and that person is correct. You may still lose your hair, unfortunately.
And the hair, just so we all understand, because again, one of the reasons why I started Learn Look Locate is because I felt incredibly ignorant about so much, and I'm not sure if everyone really understands because I didn't. Why is it that we lose our hair if we need chemo? So everyone, don't know, when diagnosed, it's big, I was out looking at wigs. I'm like, oh God, because that's going to happen and da-da-da. Yep. And I was fortunate I did not need chemo, and I had testing and all of that, genomic testing. So that's something I do want to bring up, that genomic testing is really important for people to know because it can help determine, right, Dr. Singh? Okay.
Correct. If you're a high risk on the genomic testing, whether it's oncotype, mammoprint, those people who are still hormone positive would benefit from chemotherapy, and that chemotherapy we're talking about would include the red devil. So yes, you're right. I mean, that's why I said pretty much all breast cancers could have this to get this.
So the hair follicles, because the chemo is killing the good cells, that's killing, because hair grows so fast. I'm trying to see if I know
rapid dividing cells. So skin and hair are rapidly dividing cells, and so those are affected, and that's why you use them.
And heart is a biggie.
Right. And before we get to the heart, I was just thinking about a couple of other ones, because the heart's a big one. It can cause nausea, and so big risk factors for that. Understanding that we have great ways of preventing nausea. There's actually 5 pathways in the brain that you can block that would prevent nausea. So, before anybody gets a drop of this medication, you should be getting many different anti-nausea medications to help combat that. Then you should also have a group of anti-nausea medications to take while you're at home. Usually nausea, and when we talk about the red devil, there's certain doses that we give. But the typical dose that we give for a regimen called dose-dense DC, which is the most common, does cause nausea. So most people will be subject to nausea. So it's important to have that discussion with your oncologist about what am I doing to help reduce my risk of nausea and vomiting. Because that's a really debilitating side effect that most people could get that we can try to prevent. And then the other big one that's common is something called mucositis, which is basically sores, oral sores in the mouth and in the esophagus when you're swallowing. Now, we do also have solutions that we can use to help reduce that too. So just being aware of that, because not only does chemotherapy suppress your appetite, not want you to eat, can cause weight loss, but if you are dealing with sores in your mouth to try to eat and you can't eat, combating the ability to keep your weight, maintain your weight, and obviously be nourished, because you need to be nourished, sleep with heavy.
Yeah, it affected my mouth, thrush, but yeah. And it goes away, I take it? Yeah?
It does. But ask your oncologist, it's something called magic mouthwash. That's exactly what it's called. It's a compound of many different drugs, which definitely helps with that.
Okay. That's really, really good. Thrush, well. So
I think I saw someone there talk about their nails. So you can make your nails very brittle. They can also fall off. And it can also cause something called hand, foot, mouth, which if anybody's had kids is quite common. But it can happen. So if you start noticing a rash on your hands and the soles of your feet and start getting ulcers in your mouth, that could be due to the red devil.
I've heard that when you go to the bathroom, it can be red.
Yeah.
So
all of that kind of comes with that stigmata of the red devil, right? Not only does it look like that when it's taken going into your body, it looks like that when it's coming out.
Oh, and the last thing I wanted to ask is somebody wrote me, and I never knew this, that whoever administers this comes in a hazmat suit. Is that correct?
So not necessarily hazmat suit. When they're mixing it under the hood, they definitely have to, and they have to cover it with a special bag that helps, because light can affect the way the medication metabolizes.
So is it affect the person that's administering it? Is there a danger to it?
No, shouldn't. No, not if they're taking all the right necessary protocols for how they're mixing it and putting it together.
Okay.
But that's a great question to involve the pharmacist from Walgreens too, I think. So,
it is. Thank you for bringing it up.
Yeah.
Yeah, that's really awesome. I'm glad you brought that up, guys. Just those of you that don't know, Learn the Flowcade has developed a strategic partnership with Walgreens, and Dr. Singh will be helping me with that. And we're going to go live with Pharmacist, a specialty pharmacist. This is not a regular pharmacist, guys. These are pharmacists specialized in oncology. So a lot of people don't know that they exist. There are about 300 of them across the United States, and it's exciting. You want to say anything, Dr. Singh?
Yeah, I think they're invaluable. I mean, they in the world of oncology, as we broaden and people become subspecialized, just the drugs itself are very intricate. There's new drugs being published almost every month. And these pharmacists are amazing. They know so much about all of this. And I think this is an exciting partnership. I think it's going to really do well for the public in terms of getting the knowledge out there. And so stay tuned.
Yeah.
I think it's really, really great.
Yeah, it's been a long time coming, and I'm beyond honored and excited to be working with them. And when we'll be going live, it'll be the things that they can do, guys, is also have access to, kind of this very, very special medications, correct? And we need more education. Yeah. Kathy's a big fan. I'm trying, Kathy. I'm 24/7, my friend.
Okay, so now I'm going to jump into the cardiotoxicity. So basically, this is the big deal with the red devil.
Yeah,
this is what we really, all oncologists, all patients getting this drug, everybody should be highly alert about this. And
absolutely.
So anybody getting this drug, needs to be assessed at a baseline about how their heart is functioning. Because what these drugs can do is you can affect the heart in different ways. There's an acute way and a chronic way. The acute way is anybody getting this drug in the short term could develop what we call an arrhythmia, which is an irregular heartbeat. That can come in many different fashions. They can get chest pain related with this. There's a lot of cardiac symptoms. So if you're getting chest pain, if you're getting shortness of breath when you're walking a couple of feet, that's not normal for you. These are alarming symptoms. You know, you need to get something like an EKG, maybe you need to see a cardiologist. You need to be worked up thoroughly for this. But the bigger one that everybody talks about is this chronic side effect with these anthracyclines or the red devil, and that's affecting the heart function. It can reduce the heart function in how it's beating. And we look at that by looking at something called the ejection fraction of the heart, meaning how hard is it actually pumping. And that we know is directly related to how much of the drug you get. So we know in a lifetime of someone who has a normal, healthy heart, never had any problem, can never get more than 450 milligrams per meter squared. This is just a dose. This is not for anybody to memorize, but it's a total dose from the cumulative of someone's lifetime. Now, to give you an idea, the typical person who gets that regimen that I'm talking about, this dose dense AC, only gets about 240 for the whole course. So anybody who's getting this drug who ends up having a normal heart should be fine, should not have to worry about this. But even with that situation, the oncologist will talk to you about getting your heart scanned every 3 months while in treatment. Because you want to make sure, what if something happens between that time frame, we see a sudden drop in your heart function? That's a big red flag and needs to be worked on. Because the last thing we want to do is someone's heart can become weak and then not have a good quality of life when we're trying to treat the cancer. And I think that's really important.
Absolutely. Yeah, I read a lot about that. There's only a certain amount in one's lifetime that they can have this red devil.
And there's more nuances to it, like the oncologist should risk stratify each person. You know, do they have diabetes? Do they have other risk factors for heart disease? Because that also plays into how much we think they may or may not be able to get of the drug.
Yeah. I do want to call out that Dr. Singh has dedicated his time and expertise on a page on the website. It's rather brief, but it is an overview of the red devil. There's also another page all about chemotherapy, all of the different types of the breast cancer treatments in the chemotherapy, and the role of an oncologist and how important that is. You know, that you're supposed to be
like a 50,000-foot view of everything, but I think at least it can get more out there, and then you can focus your questions. You know, I think anybody can take anything away from it. It's knowing that now you know at least the basic, and then now you feel better armed when you go and talk to your oncologist.
Yes.
About how to ask those questions that really get you the answers you need to understand what you're getting.
Yes. And before we wrap up, because I want to be respectful of your time, does anyone have any questions? Any questions, guys? I'm really grateful that it is your half an hour here. And we could go on for hours. This is a very delicate topic and really important for us.
It's a great topic. I mean, I think there's so many things we could talk about, right? I mean, and we didn't even include it. Like I said, the immunotherapy, I think, is a huge topic. I think there are other, and I didn't talk about this, but if for some reason you're not a candidate for red devil, there are excellent other treatment options. So knowing that there are other things you can get, so don't feel bummed out that you couldn't get the red devil. There are other excellent options that you could have received.
We do have one about chemotherapy that induced stem cell mets later.
I'm trying to understand what you mean by stem cell mets, but I think there's a risk of leukemia, which I didn't say, but there's a small risk of leukemia in the first 1 to 3 years after getting this drug, and so that is a concern at all times when you get this drug.
Yeah.
We don't do, and if you're talking about stem cell transplant, that was inferior. That got shut down in the 90s. We don't transplant breast cancer patients. So.
Well, thank you, guys. I'm so grateful. This will be, for those of you that missed this or have friends that want to see it, she's metastasis.
Okay. It shouldn't, the whole purpose of this is to prevent that, Kathy. But it shouldn't induce metastasis. That should just kill any microscopic disease anyway.
One other thing I wanted to let you guys know that I have a newsletter that'll be coming out with Dr. Weaver. He's the other medical oncologist, and this is going to be incredible. It's all the latest and greatest news, tests, treatments, so I'm excited about that. Just want to get to the forefront. And Dr. Singh will continue to do great videos to help keep that human touch on what's going on, right?
More to come. I'm excited to work with you, Cynthia. You're doing a great job. Thanks for having me.
Yeah, always. We love having you. Yeah, thanks, guys, for joining, and we're going to sign off and go on the Reels grid for later watch. So thank you, everyone.
Absolutely. Take care, guys. Bye.
Have a good evening.
Good evening.